Do you get nervous every time an ECG is handed over to you? Do you get confused which lead to focus on while reading an ECG? Then welcome to my channel Catch22, which will help you decode ECGs. Hey guys, welcome to my channel Catch22. I am Dr. Tirthankar Basak. Today we are going to talk about ECGs. So ECGs, I have realized during my undergraduate period and residency as well, is one of the most frequently ordered investigations and also a low-key intimidating topic from exam perspective. So although ECG is a broad spectrum, we are today gonna talk about the most common pathologies that are seen in ECGs, and also together we are going to form an algorithm that will help us reach the diagnosis of the common pathologies very easily, so that we never miss out on the common pathologies. So let's start. Let's begin forming an algorithm so that whenever you are handed over an ECG, you can say with confidence that yes, I have got this. First up, we'll be looking at something very basic. We'll be rushing through it, the conduction system of the heart. Now we all know that the conductive tissue of the heart includes the sinus node, the AV node, the bundle of His, and left and right bundle branch, followed by the Purkinje fibers. Now we'll be looking at the changes that are seen in an ECG tracing as the impulse originates from the sinus node from perspective of lead 2 of the ECG. Firstly, as the impulse originates from the sinus node, we get the atrial contraction which leads to the P wave. Followed by that, the impulse is conducted from the SA node to AV node, which gives the PR segment. Now, followed by that, as the impulse travels through the AV node bundle of His and the left and right bundle branches, we get the ventricular contraction, which gives rise to the QRS complex. QRS complex, and finally you get what you see here is the T wave, which results from the ventricular repolarization. Now we'll be looking at ECGs proper. So whenever you are handed over an ECG divided into two parts, the arrhythmias and MI, that is myocardial infarction. You can look for arrhythmias earlier, followed by MI, or vice versa. If you know the clinical scenario, symptoms such as palpitation or syncope is more likely to lead you to ECGs with arrhythmia, while syncope such as chest pain or diaphoresis is more likely to lead you to pathologies like MI. So, in cases where you are searching for arrhythmias, the most important lead to look for is the lead 2, while for MIs, we'll have to look at all the leads. We'll be coming to the leads later on for MI. Remember, for arrhythmias, always look at lead 2. We'll be looking at the common arrhythmias in this video, which includes SVT, that is supraventricular tachycardia, atrial fibrillation, atrial flutter. We'll also be looking at the ventricular tachycardia, ventricular fibrillation, ventricular flutter, the first degree, second degree, and third degree heart blocks. In second degree, we'll be looking at Mobitz 1, Mobitz 2, and advanced second degree heart block. If possible, in this video, I'll also tell you about the left bundle branch block and the right bundle branch. Okay. In MIs, we'll look at the ST elevation MI along with the wall which is involved, and also the non-ST elevation MI. So now whenever you are handed over an ECG strip, divide it into two parts. One is for arrhythmias and another one for MIs. You can look for MIs first, then arrhythmias, or vice versa, depending upon the symptoms of the patient or on your own will. So we'll be looking at arrhythmias first. Now we'll be trying to create an algorithm for diagnosing arrhythmias in our ECGs. Once you get a ECG strip and start searching for arrhythmias, first thing you should do is to calculate the rate. For the rate, the RR interval is calculated as shown in the picture. Then you take the number of small squares between the two RRs, then divide 1500 by the number of small squares to get the heart rate. Now the heart rate, if it is greater than 100, then it is known as tachycardia. If the heart rate is less than 60, then it is known as bradycardia. let's look at the tachycardia side first. That means you got the ECG strip, you calculated the RR interval, and you got the heart rate to be greater than 100. Next thing you should check at should be the QRS complex. Now the QRS starts from the beginning of the Q wave to the end of the S wave. You calculate the number of small squares. If it is greater than 3, if it is lesser than 3 small square, lesser than or equals to, then it is narrow QRS. If it is greater than 3 small squares, then it is wide QRS. In this picture, the column 1 has narrow QRS complexes from V1 to V6, while the second and third column has wider QRS complex. Now let's say you got narrow QRS complexes. Now once you get narrow QRS complexes, you search for the regularity of RR. Now if you get a regular RR, let's say you got a regular RR interval. Next thing you should look for is the presence of P waves. If you get no P waves with a regular RR, then it is known as SVT or supraventricular tachycardia. Now, let's say if you got an irregular RR interval, now you divide it into two parts. After you got irregular RR intervals, if you see certain small waves in front of every QRS complex, which is known as fibrillatory waves, which are just slight depolarizations in front of QRS complexes, then it is known as atrial fibrillation. Now, after you got irregular RR intervals, if you see certain sawtooth-like waves in the basal electrical line with an occasionally absent R wave, then that arrhythmia is known as atrial flutter. Now, in these examples, the first wave has a narrow QRS complex with a regular RR and no P waves. Instead of P waves, only T waves are there. Then, so it is an example of SVT. In the second one, there are irregular RR intervals with slight depolarizations known as the fibrillatory waves in front of before every QRS complex. This is known as atrial fibrillation. The third one has sawtooth-like waves with occasionally absent R waves in the ECG, and hence is an example of atrial flutter. So we have seen an algorithm where we had got calculated the rate, got tachycardia, looked at the QRS, got narrow QRS complexes, and depending upon regularity divided it into atrial fibrillation, atrial flutter, and SVT. Now let's check what to do if we get a wide QRS complex that is of greater than 3 small square. Next up, we should search for P waves. Now in the ECG strip, there can be two options. P wave can be present or P wave can be absent after getting a wide QRS complex. So if P wave is present, the ECG is more likely to be of LBBB or RBBB, that is left bundle branch block or right bundle branch block. Now, if P wave is negative, what you need to do is search for three patterns. The first pattern has a rate of 100 to 250, is regular. If those two boxes are ticked, then the ECG is more likely to be of ventricular tachycardia. Now, in the second pattern, the QRS complexes are chaotic and unorganized, and if that's the case, then the ECG is of ventricular fibrillation. And lastly, the third pattern. In the third pattern, we see that the QRS complexes are organized and are sinusoidal in shape and oscillatory in pattern. So, if that's the case, then the ECG strip is of ventricular flutter. Now let's look at three examples and try to solve it as per our algorithm. Now see, in all the three pictures, firstly we need to look at the heart rate and it is greater than that of 100 seconds. That is, all the three examples are tachycardia. Now next up is to look at the QRS complexes, and in all the three examples the QRS complexes are greater than 3 small squares and hence are that of wide QRS. Now next step is to look for the P wave. Now P waves in all the three examples are absent. Now our job is to search for three patterns. Look at the first ECG. In this ECG the rate is that of 100 to 250 and is regular. and hence as per our algorithm it is that of ventricular tachycardia. In the second ECG, the QRS complexes are chaotic and unorganized, and hence as per our algorithm it is that of ventricular fibrillation. And lastly, in the third ECG, the QRS complexes are organized, sinusoidal, and oscillatory, and hence it is that of an ventricular flutter. Now, see, you can solve all those three wide complex tachycardias as per our algorithm. Now, we'll see what to do if we get a heart rate of less than 60 beats per minute, that is bradycardia. The next thing that you ask yourself is if every P wave is followed by a QRS complex or not. If the answer is yes, you calculate the PR interval. I'll show you what the PR interval is. If the PR interval is greater than 5 small square, that is 0.20 seconds, then it is a case of first degree heart block. If it is less than 5 small square, then this is a case of sinus bradycardia. Okay, see here the PR interval which starts from the beginning of the P wave to the beginning of the QRS complex is of almost 9 to 10 small square, which equals to 0.38 seconds. So this is an example of first degree heart block. Now, if every P wave is not followed by a QRS complex, you search for any relation between the P and the QRS complex. If you see that that there is no relation between P and QRS, that is, the P waves are occurring at their own rhythm and QRS in their own rhythm, then it is known as complete heart block. For example, in this ECG, you see the P waves are occurring at their own rhythm, while the QRS complexes are again occurring at their own rhythm. Both of them are regular, but there is no relation between them. So this is an example of complete heart block. Now, after the complete heart block or the third degree heart block, let's shift to a pattern where only some P waves are followed by QRS wave. Now, if some P waves are followed by QRS waves, you again look for three patterns. In the first pattern, there is gradual prolongation of the PR interval and a sudden drop of a single QRS. For example, in this ECG, there is prolongation of the PR interval followed by a QRS drop. This is known as Mobitz type 1 second degree heart block or second degree heart block Mobitz type 1. Now, the second pattern is where there is a fixed PR interval without any prolongation followed by a single QRS drop. This pattern is known as the second degree heart block Mobitz type 2. For example, in this ECG, the PR interval remains constant, which is followed by a single QRS drop after the P wave. This is known as Mobitz type 2 second degree heart block. There is also another type of second degree heart block known as the advanced second degree heart block, which is beyond the scope of this video. To oversimplify things, in it there is a drop of more than one QRS complexes, unlike Mobitz 1 and Mobitz 2. For example, in this ECG, there are drops of 2 or 3 continuous QRS complexes. So, this is an example of advanced second degree heart block. The drop of QRS complexes are marked in blue asterisks, as you can see, following the P waves. Continuously, two QRS complexes or three QRS complexes are dropped. Again, in ECGs where every alternate QRS complexes are dropped, uh, which is known as the 2:1 heart block, are also considered under advanced second degree heart block. This is usually seen due to digitalis toxicity. Why is it considered advanced is again beyond the scope of this video. So now we have seen under bradycardia, first degree heart block, the complete heart block or the third degree heart block. In second degree heart blocks, we have seen Mobitz 1, Mobitz 2, and the advanced second degree heart block. This completes our arrhythmias. So now we are done with arrhythmias. I hope your concepts are clear. Now we'll be looking at MIs. So before starting with MIs, you need to understand something that people who discovered the leads of ECGs actually wanted to look at the heart or the depolarization of the heart in two planes. One is the frontal plane, another one is the horizontal plane. So the leads are placed in frontal and horizontal plane in such a manner that you can look at the depolarization of the heart from different directions, so that once MI occurs, there will be changes in the depolarization. So you can understand which wall of the heart is involved by looking at the particular lead which represents that portion of the heart. So let's start understanding where which lead is placed first, or which part of the myocardium is represented by which lead first. Then we'll shift to STEMI and NSTEMI. Now in frontal plane, the leads include 1, 2, 3 and AVL, AVF, AVR. So uh, consider this the human heart, and now if you want to look at the directions represented by each lead, the lead 1 is placed here, 2 is placed here, the lead AVF is placed below, the 3 also is placed in the inferior position, the AVR is placed here and AVL is placed here. All these leads represent the frontal plane or the vertical plane of the heart. Now next up is the horizontal plane of the heart. In horizontal plane of the heart, the leads include V1 to V6. The V1, V2, V3, V4, V5, V6 are placed in the horizontal plane. V1, V2 represent the septal position of the heart, V3, V4 the anterior wall, and V5, V6 the lateral wall. In the vertical plane, as you can see, lead 1 and AVL represent the lateral wall, while lead 2, 3 and AVF represent the inferior wall of the heart. Now, if we want to tabulate all those information, let's divide it into wall and the leads representing the area of the wall. The anterior wall is represented by V3, V4. The septal wall, as you know, is represented by V1, V2. The lateral wall by V1, V6, V5, V6 of horizontal plane, and lead 1 AVL of frontal plane, and the inferior wall by 2, 3 AVF. Now we can divide myocardial infarction into two parts. One is the NSTEMI or the non-ST elevation MI, and the other one is the STEMI, that is the ST elevation MI. Now in NSTEMI, we should remember three features. The first one is the clinical signs. The typical clinical signs includes chest pain, diaphoresis, and other signs. The second one are the ECG changes, and the third one is the gradual increase in cardiac troponins. Now remember this always, ECG changes in NSTEMI can be anything except for ST elevation. Among the above three, the presence of any two can indicate NSTEMI. Now let's shift to STEMI. Now before understanding STEMI, we should understand the concept of J point and the cutoffs for considering ST elevation in different leads. ST segment elevation at the J point in two contiguous leads with cutoffs of greater than 2 mm in men or greater than 1.5 mm in women in leads V2 and V3 or greater than 1 mm in other leads is considered STEMI. For example, in this ECG, the point where the QRS complex meets the T wave is known as the J point. It is indicated by this blue arrow. This point is to be considered while considering STEMI. In this ECG, the strip is taken from lead V3. You see from the isoelectric line, the elevation of J point is of 4 mm. Therefore, it is considered to be ST elevation by the definition. Now let's start with a quick recap of the position of the leads. So the vertical leads are placed in this manner. We already know 1, 2, 3. The the AVL, the AVF, and the AVR. For the horizontal leads, this is the sternum, and the leads are placed in the following manner: the V1, V2, V3, V4, V5, and V6. V1, V2 represents the septal position of the heart, V3, V4 represents the anterior position of the heart, and V5, V6 the lateral wall. Now, let's divide it into the area of the myocardium involved and the area and the leads that will show ST elevation if that particular area is involved. For septal, it is of course V1, V2, we already know. For anterior wall, it will be V3, V4. See, things become simpler now. For lateral wall, the leads will be V5 and V6. And for the inferior wall, the leads will be 2, 3 AVF. I guess we already had figured this out by now. Okay, so now let's get introduced to another concept of reciprocal ST depression. See, the reciprocal changes means that there will be subsequent ST depression in leads placed diagonally opposite to the involved myocardium. Okay, so this reciprocal ST depression helps us to diagnose ST elevation MI more specifically. It increases the specificity of our diagnosis. For example, for anterior and lateral wall, the ST elevation will be there in V3, V4 and V5, V6, while ST depression will be in 2, 3 and AVF. For inferior wall, ST elevation will be there in 2, 3 AVF, while reciprocal ST depression will be in 1 and AVF. However, usually for septal ST elevation MI, there are no reciprocal depressions or no leads showing reciprocal depressions. Now, for those of you who have already figured out that I had missed writing 1 and AVL for lateral leads, lateral myocardium ST elevation, have successfully understood the concept of position of ECG leads by now. So you now know the area involved, the reciprocal changes, the leads showing ST elevation. I hope those concepts are clear to you by now. Now we have created an algorithm for arrhythmias and MIs as well. I hope things are clear for you. Let's try solving few examples together. We'll be having the example on one side and and our algorithm on the other, and we'll be trying to solve the ECGs together. So let's start. Now let's solve some examples. For example, in this patient presented with syncope and palpitation. Now by now you know that this patient might have arrhythmias. So you also know which lead to look at. The lead we should watch out for in this patient is lead 2. So here is the lead 2. Now we have found the lead of focus here, and our next step will be to look at the RR interval as per our algorithm. Okay, now see here the RR interval, the smallest RR interval is of 12 small squares. So the rate will be 1500 divided by 12, and it will come to be around 120 to 140 beats per minute. So now this ECG shows tachycardia. Our next step as per algorithm is to look at the QRS width. Now it is less than 3 small squares, so it shows narrow QRS. Now we should look at the regularity of the RR. You see here the difference between two R waves keeps on changing. So that means the RR interval is irregular. So as per our algorithm, after finding irregular RR, our job is to search for fibrillatory or sawtooth waves. This ECG shows fibrillatory waves as shown here, and hence this ECG is of atrial fibrillation. Now here is another example. Here the ECG clearly shows bradycardia. So we'll shift to the bradycardia algorithm. Once we find out it is bradycardia, as per the algorithm, we should be asking if every P is followed by QRS wave. Again, we should be focusing on lead 2 since this is a case of arrhythmia. So now if we ask if every P is followed by QRS, we see that some P's are followed by QRS whereas some other are not. So as per the algorithm, our job is to search for the three patterns now. So we'll be looking, you see here only one QRS drop is there after P waves. So clearly it is not a case of advanced second degree. Now let's focus on the PR interval. Here you see the PR interval is more or less fixed. Here there is no gradual increase in PR before the drop of the QRS complex. Hence, this is not a case of Mobitz 1. So since there is fixed PR and along with that a single QRS drop is there, hence it is a case of second degree heart block Mobitz type 2. Now in example 3, a patient has come to us with chest pain. We'll be going through the lead combinations one by one, searching for an area of the myocardium involved. For example, V1 and V2 here shows no ST elevation, no significant ST elevation, hence the septal region is not involved. The V3, V4 also shows no elevation, therefore anterior portion is not involved. The lateral wall represented by 1 AVL V5 V6 also shows no elevation, hence the lateral wall is also not involved. However, you see here there is significant J point elevation in 2, 3 and AVL. Not only that, along with that you can also see reciprocal ST depression in 1 and AVL. Therefore, as per our algorithm, this is a case of inferior wall MI. So this brings us to the end of the video, guys. During the past 15-20 minutes, we have created an algorithm for arrhythmias and MIs as well. However, I haven't told you about two pathologies, that is right and left bundle branch block. Comment below the criteria for right and left bundle branch blocks. From now onwards, try solving more and more ECGs until and unless it becomes a reflex to you. See you in the next video.